Thank you very much, and yes, welcome to this lunchtime lecture. I have a very loud voice. Is this overwhelming for you? It isn't. It sounds really, really loud here, so I'll just have to get used to that. Yes, coming through the snow and the hail and the dreadful cold, it's really wonderful that you've all been able to make it today. What I'm going to do is try and answer the question, can HIV treatment stop the AIDS epidemic? And I'm essentially going to do that as a for and against the argument. But because World AIDS Day is tomorrow, the 1st of December, I just thought I'd inform some of you and remind others of the current situation, which is that there are estimated to be over 33 million adults and children living with HIV, and these are the most recent data from UNAIDS. And of course, the vast majority of these people live in sub-Saharan Africa, where the AIDS epidemic has had its greatest impact. In 2009 alone, UNAIDS estimates that 2.6 million people became newly infected. So we're talking about, again, a significant number, with the greatest proportion of those people once again living in sub-Saharan Africa. And deaths last year from AIDS were near the 2 million mark. Again, sub-Saharan Africa accounting for the majority of those. Now, in the UK, it's well, next year it'll be 25 years since I started working in the HIV AIDS field, and the Health Protection Agency estimates that by the end of next year we'll have 100,000 people living with HIV in the UK. So nothing like the situation in sub-Saharan Africa, but this is an infectious disease. It causes a huge morbidity and mortality, and therefore it is still to be reckoned with in the UK. But we have good news in the UK to some extent. Now, this graph shows the top line is diagnoses of HIV from 1981, when AIDS was first recognized. And you can see, and the blue line is diagnoses of AIDS, the yellow deaths from AIDS. And you can see that amongst men who have sex with men, there was a rapid uptake of HIV antibody testing when that became available, so we were able to see a huge increase at that point. But what happened in 1996 was that highly active antiretroviral treatment was introduced, and that had a huge effect not only in the UK with MSM, but for drug users, for people in developed countries across the world. And what you can see from the graph is a significant reduction in diagnoses of AIDS, of deaths from AIDS. But you can see from the orange line that more people were living with HIV because treatment was so successful. So we have this situation where people are not in large numbers as they were dying of HIV and AIDS, but in fact living with it on antiretroviral treatment. It has been the most dramatic, it has had the most dramatic impact. So now people are interested in whether HIV treatment itself can be a contributing factor to reduced incidence of HIV, and I'll explain how. So the prospects for preventing HIV have been boosted by observational data that suggests that antiretroviral treatment actually reduces individuals' infectivity. Now, in some ways this is an established concept, because we know that antiretroviral treatment prevents mother-to-child transmission. So if a mother is HIV positive, if she takes treatment, her child can be, her baby can be protected from HIV. We've seen in very large meta-analyses and systematic reviews of studies of heterosexual transmission where one partner is HIV positive and the other negative, that if there is successful suppression of the virus, then transmission is very unlikely to occur. And in fact, the Swiss produced a statement a few years ago which said that if the partner who was positive was on HIV load, there's no other then situation, the uninfected partner would remain uninfected. We've also recently seen the results of a vaginal microbicide trial. This was reported this year, which showed that in South Africa, the use of a topical microbicide using an antiretroviral treatment could reduce the acquisition of HIV by 39% in women who used it. There's also been a recent study, literally last week, in the New England Journal of Medicine, which looked at men who have sex with men taking antiretroviral treatment who are negative, and again, this was found to have a 44% protection. So ART is increasingly being seen as a positive contribution to possible reduced incidence. So the proponents of the argument say that really if you control HIV, not only in the individual but at a community level, the more people you get on treatment, the less likely it is that transmission is going to occur. So I'm going to look at the data that support that, data that perhaps question the extent to which we can use ART as a public health measure to prevent transmission, look at the global challenge fairly briefly, and then make some concluding remarks. So as I said, I'm going to essentially take this as a for and against argument. So in favor of the argument, and I'm going to focus on, to make it in a sense more manageable, I'm going to focus on men who have sex with men. If this is going to work, we need to demonstrate this in smaller epidemics such as in the UK before it can be properly rolled out to larger more generalized epidemics such as in sub-Saharan Africa. So the first point here is that studies show that there's reduced RNA HIV in semen who are highly adherent to antiretroviral treatment. That is to say, these men are less infectious. So this is quite an old slide, but it shows very, very clearly the controls are those people identified in the green, the people receiving potent antiretroviral treatment in the blue. And it shows that when people are taking antiretroviral treatment, the presence of HIV RNA in semen is massively reduced. So their infectivity is massively reduced. We know this also from observational studies in sub-Saharan Africa. So for example, here, Quinn et al. Show that there are no transmissions if plasma viral load is below 400. So if viral load is low or undetectable, you find very few, if any, transmissions. The other arm of this argument says that the success of ART continues if people are adherent. Viral suppression is possible to maintain. These are data from colleagues at UCL in the Department of Infection and Population Health, Andrew Phillips and Caroline Sabin, on the Royal Free cohort, which show that people can have undetectable viral load very quickly after taking antiretroviral treatment, and if they sustain the treatment on a daily basis, are completely adherent, then we're seeing 95, 98, 99% of people successfully suppressing HIV. Successfully suppressing HIV means that they are living, they are not dying of AIDS. We've had massively improved efficacy on current regimens, so viral load becomes undetectable more quickly. These drugs are very, very powerful, very successful, and there's reduced viral rebound. That is to say, people are able to maintain those low levels, undetectable levels of virus in their plasma. But these are data that are well established, have been around for some time. The more exciting data have come through in the last year or so, and these are from observational studies of real populations seeing reductions in new diagnoses or incidence. So one of the first of these papers came from San Francisco. San Francisco, you'll remember, was the epicenter of the HIV epidemic in the United States. The first cases came from Los Angeles, New York, San Francisco in 1981. So well established as the epicenter for AIDS in the US. Now what Mupali Das and her colleagues have found was what they called decreases in what they called community viral load. That is, an average of all people who are on antiretroviral treatment, an average of their viral load. That the reductions in that average over time are associated with reduced incidence in the city. So the blue blocks here are the average, the mean community viral load, the average of all measured viral loads in people in treatment. The middle line is newly diagnosed HIV cases, and the top line in the darkest red an estimate of reduced incidence. So these data show that as community viral load goes down in the blue blocks, so do diagnoses of HIV infection. And the authors also argue that this is resulting in reduced incidence. The difference between diagnoses and incidence is that diagnoses are in people who present to services and are identified as being HIV positive, whereas incidence is a measure of new infections taking place in any particular period, usually a year. So these are strong data. But the authors recognize that there are some limitations. So, for example, viral load results were missing for 26% of the people on the registry that they used, and so there's imputation of missing data. The incidence data are not measured incidence. They are estimates of incidence using an established algorithm. So there's an issue there about the fact that it's an estimate. And of course, you can't have, they also recognize that the community viral load is only measuring virus in those people presenting at services who have a viral load test. It cannot measure people who are recently infected and unaware of their infection, people with established infection who either are unaware of their infection or not in contact with services. So they do give, in a sense, a health warning to the data, but they are persuasive. So persuasive, in fact, that in San Francisco they have changed their policy such that every person newly diagnosed with HIV is immediately offered antiretroviral treatment. A major change in the approach to providing antiretroviral treatment, which previously was associated with a given viral load and or CD4 count. San Francisco is not the only place. In British Columbia, they've found a similar sort of situation. And again, this is about providing HIV treatment on a widespread basis to impact new diagnoses. And again, a very persuasive table here showing, figure rather, showing in the red line at the top the reducing number of HIV diagnoses as the blue line, which is as the blue line increases, which is the number of people on antiretroviral treatment. And they had a particular focus on injecting drug users, and so new HIV diagnosis in the injecting drug user population is shown below. So both the San Francisco and the British Columbia data are seeking to demonstrate an association between increasing number of people on antiretroviral treatment and reducing diagnoses. Now again, the authors counsel caution here with regard to the data. They say that it's an ecological analysis, so therefore you cannot impute causation. It is a set of associations that they are demonstrate. Having said that, they rather then ignore that statement about it being an ecological analysis and do in fact impute causality. They say that these are overwhelming data, these are so strong that we really must believe it. And again, like San Francisco, the proposal in British Columbia is to have a new strategy whereby everybody newly diagnosed with HIV immediately goes on treatment. So we've got both, we have the scientific data regarding HIV RNA and it's the impact of ART on reducing that, the durability of viral suppression on ART, and these observational data. So altogether, this is a strong case. However, understandably, in the for and against, there's an against argument, and there are other data which are perhaps not quite so supportive. The first of these suggests that there's risk of transmission in primary HIV infection. That is, immediately after becoming infected, you are at a very high level of infectivity. But also, if you're untreated as the disease goes on, you also continue to be infectious. So this shows the natural history of HIV, and here is the massive increase in HIV RNA measured after exposure to the virus. It then goes down, but then if the disease is untreated, if the person continues to live with HIV, they eventually move into frank AIDS, to the opportunistic infections and other problems associated with AIDS, which eventually kills people. And again, at that point, there is a massive increase in HIV RNA, making people highly infectious. Now, phylogenetic studies use both molecular and epidemiological data to, in a sense, map or follow the way that a virus moves into populations, changes over time. It's possible to use these techniques to do that. And one of the consequences of using phylogenetic techniques is that we're able to indicate, or we're able to identify whether an infection has occurred as a result of somebody recently infected or at a later stage of the disease. And in Canada, Brenner et al. Estimate that around about half of all new infections come from somebody who occur as a consequence of sexual transmission with somebody who's also very recently infected. In the UK, we have estimates of around about a third and about a quarter. So looking at this last study, which was undertaken by colleagues in Brighton, but also at UCL and the Health Protection Agency, of 40 individuals where they were certain that they could determine the recency of infection in those people, they found that the transmission was likely to have occurred in 10, from 10 people who were very recently infected. But one of the reasons for showing this is that they also found that if people were untreated and that is chronically infected, then nearly half of the infections occurred from those people, so people further into the disease. There were 2 infections from people who were actually on treatment, and 9 infections from people who had the disease but were interrupting treatment, so they'd stopped their treatment. So this demonstrates that, admittedly in a small number of people, but there is a range of possible transmission events associated with people in different stages of HIV disease. Now, the good news I showed you earlier about reduced HIV RNA is, of course, great news, and so you'd be unsurprised to hear that with people not taking antiretroviral treatment, in a review of 6 studies, between 31 and 79% of men in these studies were shedding HIV. But of greater concern is that of those on antiretroviral treatment, again between 15 and 50% were shedding HIV from the genital tract. So there is a problem even in the presence of antiretroviral treatment. But I suppose an even stronger argument is the challenge that current testing availability, uptake and frequency are not at levels to sufficiently address undiagnosed infection or recent infection. So these are data from GUM clinics in the UK, genitourinary medicine clinics, sexual health clinics, where people go for treatment of sexual health problems, STIs, HIV, and so on. And this shows on the top line the proportion of men who have sex with men receiving an HIV test who've gone to a clinic, and the blue bands below indicate those people, those men who have sex with men who are HIV positive, who remain undiagnosed after they've been to the clinic. So here, when the routine offer of HIV testing was introduced in 2003, you can see that from around 50 or 60% of men accepting the test, this went up to nearly 90%. And although there was a reduction in the undiagnosed fraction, by 2008 it was still around about 1/3 of HIV positive men were leaving clinics without a diagnosis. So they'd not wanted to be tested in that circumstance. They'd been tested but hadn't stayed around to get a result. The HPA, the Health Protection Agency, estimates that around about 1/4 of people living with HIV in the UK are unaware of their infection. But if we look at community recruited samples, not samples recruited in clinics, but community recruited samples, we see a rather different picture. We've been doing work for many years now in Glasgow and Edinburgh, in London, and in Brighton and Manchester, asking men in bars, gay men in bars, clubs and saunas to self-complete a questionnaire to provide us with a sample of oral fluid, which is then subsequently tested for HIV. So we can connect up what they've said in their questionnaire with their HIV antibody status. And between 2000 and 2005 in the UK, in these cities, we found very high levels of undiagnosed HIV infection in men who have sex with men. So in Brighton, in a sense, the best place, 1/3 of men who were HIV positive, who completed the questionnaire, were unaware of their status. They didn't know they were positive, or they thought they were negative. In London, it was 44%, and it was as high as 48% in Glasgow. So this is to say we have people with undiagnosed HIV infection, many of whom are engaging in sexual risk behaviors associated with transmission. And so the undiagnosed fraction in a community setting is significantly higher than that's seen in the clinic setting. It's not just a matter of undiagnosed infection, it's also a matter of late presentation. If you are unaware of your HIV status and you continue to live with the disease until you start to get symptoms of it and you present very late, then you significantly reduce the opportunities of improving your health with antiretroviral treatment. And even in Europe, jurisdictions where antiretroviral treatment is readily available. There are good clinical services in the UK, in France, in Spain, and Italy, and so on and so forth. We still have exceptionally high rates of late presentation, and these data were provided by Andrew Phillips and Caroline Sabin, again at the Royal Free. Finally, there are observational data on new diagnoses and incident infection, which again give us pause for thought. So these are new diagnoses by Prevention Group in the UK, and you can see the top line are people whose HIV was acquired through heterosexual contact abroad, and the vast majority of these people were from sub-Saharan Africa, and from 2004-2005 changes in immigration and access to the United Kingdom resulted in reductions in the number of people coming to the UK with HIV infection. But if we look at men who have sex with men, sorry, these are diagnoses, so this isn't incident infection, this is about people presenting to services. So if we look at men who have sex with men, however, we see that that number of people presenting for HIV testing has increased over the past few years, and even if leveling out at the moment, still is at very high levels. This is a horrible, messy slide, but what it essentially does is show that from 2001 to 2005, in jurisdictions where, again, antiretroviral treatment is readily available, easily available, Australia, Canada, France, Germany, Netherlands, Spain, the UK, and the US, there have been increases in new diagnoses amongst men who have sex with men. We're not just talking about new diagnoses. In some jurisdictions, in some places, it's possible to look at incident infection. They've done that in Amsterdam. Important incidence data, because this is telling us a huge amount about the nature of the ongoing epidemic. And although overall HIV incidence is increasing slightly, amongst young men there have been much sharper increases in new infections. So against the argument that antiretroviral treatment can stop the HIV epidemic, there's the risk of transmission at different points when people are undiagnosed. There is still some genital tract shedding of HIV even with people who are on antiretroviral treatment. The current uptake and frequency of testing amongst a high-risk population in the UK, notably men who have sex with men, is still at levels that are far too low to possibly treat all people with HIV. And in jurisdictions where antiretroviral treatment is readily available, there are also demonstrated increases both in diagnoses and in incidence. So can HIV treatment stop the HIV epidemic in men who have sex with men? Well, yes, there's the good news story, but there's the bad news story with regard to RNA HIV. The heterosexual data are very supportive, and these systematic reviews and meta-analyses are very, very persuasive, but no transmission studies have been done in men who have sex with men in serodiscordant couples. And in fact, Andrew Phillips is leading a team of people with an NIHR grant to look precisely at this, one of the first studies in the world to do so. Whilst there's support for reduced transmission in those observational data, the ecological studies that I showed you in San Francisco and British Columbia, elsewhere we've actually seen increases in diagnoses or incidence. So you would need to certainly identify the recently infected, because this is a population that is greatly at risk of transmitting HIV. You'd need to significantly reduce the undiagnosed fraction and stop late presentation to start mopping up this group of people who are unaware of their HIV and provide them with treatment in order to reduce their the transmission from them. So that would mean massive HIV testing scale-up with more availability, numbers tested, and frequency of testing. So at the moment, for example, BEVA, the guidelines from the British HIV Association suggest that testing should be done on an annual basis. But for men at very significantly high risk, that's probably not enough. There needs to be a higher frequency of testing. Although it's clear what the benefits of antiretroviral treatment are once disease is established and it progresses, we don't know the impact of much earlier commencement of antiretroviral treatment, and the START trial is going to look precisely at that. And there is, and will continue to be, I would argue, the problem that community viral load is unmeasurable finally because of the undiagnosed fraction. What about the situation globally? Well, it gets even worse in a way. Globally, less than half of those currently in need actually receive treatment. So they're well established as requiring treatment, but only half of them are receiving it. There are 5 new infections for every 2 people actually commencing antiretroviral treatment. The WHO guidelines as when to start treatment have changed to a higher CD4 count, and this currently triples the number of individuals who should be on treatment. And the US alone would need to spend half its foreign aid budget on antiretroviral treatment by 2016 and all of it by 2024 to address the situation of antiretroviral treatment need in populations in sub-Saharan Africa. But people, understandably, are very excited by the prospect of this. Our colleagues, Marie-Louise Newell and John Imrie, who work at the Africa Centre in Sub-Saharan, KwaZulu-Natal in South Africa, have just been awarded funding from the French AIDS research agency, the ANRS, to undertake a treatment as prevention trial. Is it the case that actually getting people on treatment will reduce incident infection? You can understand why this is an important question, why people are keen to see it answered. What many of us have been arguing for some time is that you can't simply rely on one approach to antiretroviral HIV transmission. That prevention requires a multi-level, multi-intervention approach, which, yes, may positively include antiretroviral treatment. It would also include reducing concurrent STIs, which are associated with transmission of HIV, but you still need to see behavior change. You need a combination of both biomedical and social interventions to achieve highly active anti-HIV prevention. And all of this obviously in a context of support for social justice and human rights. So tomorrow is World AIDS Day. I haven't talked about the one thing that we know prevents HIV, and that is the condom. And I'd say, particularly to a younger audience here, please don't give up on condoms yet. They are low tech, unlike antiretroviral treatment. They have proven efficacy in reducing transmission. and they are highly effective when rolled out at a population level and have been demonstrated to reduce HIV incidence. I'd like to end there, hope that there are some questions, acknowledge my colleagues have been hugely helpful in putting this together, and also bring your attention to Medicine UCL's Stop AIDS Week, which occurs this week. There's a whole variety of activities taking place, including, I believe, a lecture this evening at 7:30. Go on the UCL website, you can see that. Medicine UCL supports the Médecins Sans Frontières campaign to continue to allow generic antiretroviral drugs available. These are produced in India, in Brazil, and make it possible for people to get antiretroviral treatment in resource-poor countries in sub-Saharan Africa and elsewhere. Medicine UCL supporting that campaign, and the details are provided there. So I'll stop there, and thank you for your attention.
About 4 minutes, so we can take some quick questions. Yeah.
Sorry, could you just wait for the microphone?
Oh.
Sorry. Thanks. Yeah, I was just wondering, in terms of the studies of the effect on new infections of ART, what are the ethical concerns to do with that? I mean, if you've got a control group who are maybe going to be infecting more people, how are the studies set up?
Well, you need, for any trial to take place, you need equipoise. So you need to believe that there is an uncertain, you're uncertain of the answer to the question. So yes, people know that antiretroviral treatment brings down plasma viral load and reduces HIV RNA and is associated with reduced transmission, but this is in observational studies. There could be other confounding factors which are associated with those observed reductions, and a trial where people are provided with HIV treatment immediately and other people are tested, told that they have HIV and that they should use condoms with their partners and use every other effort to prevent HIV, will hopefully answer the question whether using antiretroviral treatment early will have the desired impact. But you couldn't do the trial unless you had uncertainty about the answer to that question. So there is a problem in answering the question, because in some populations which haven't had access to condoms, in the control arm, for example, they're newly accessed condoms. Condoms are very, very successful. They're often taken up, and the level of incidence falls because of that intervention. So even in control arms, you're morally bound to provide some sort of intervention, that is, tell people how they can protect themselves. But that's the nature of trials.
Any other questions?
Yes. What sorts of other measures are used to address HIV and AIDS besides antiretroviral treatment?
Sorry, do you mean to prevent transmission, or to treat HIV?
Well, just to both, really, to reduce the how infectious someone is, and also to reduce the HIV virus.
Well, as I've shown, people on treatment are less likely, it is believed, to transmit. It's been observed in studies, so treatment's the main way in terms of the biological mechanism. But obviously there are behavioral approaches as well. People reducing their number of partners, using condoms with new partners, having an HIV antibody test to determine whether they've got HIV infection. So the prevention means are there and available and increasing as vaginal microbicides come on board. Hopefully they will develop. Their efficacy will improve. We don't know whether taking antiretroviral treatment before somebody's exposed protects them. One trial says that it does, but there are other trials taking place. We need to see that as well. So you wouldn't rely on a single trial usually to demonstrate this. You need to see a lot of data that supports completely changing your approach.
That's all we've got time for, so on behalf of all of you, let me thank Professor Hart for the fascinating lecture.
And thank you for your attention.